Welcome, everybody. This is Karen Lundgren. I'm a registered dietitian nutritionist and senior manager in medical affairs at Nestle Health Science. I will be moderating today's presentation, Preventing and Treating Malnutrition Outside the Hospital, Preliminary Considerations of Nutrition Care in Adults with COVID-19. I am very pleased to present today's speaker, Dr. Carol Ireton-Jones. Dr. Ireton-Jones received her PhD and master's degree in nutrition from Texas Women's University. Her undergraduate degree in nutrition and dietetics came from Texas Tech University, where she also received her clinical training. She developed the Ireton-Jones equations for estimating energy requirements in hospitalized patients, and these are widely used nationally and internationally. She was presented the Distinguished Nutrition Support Dietitian Services Award from Aspen in 2018. Dr. Ireton-Jones is in private practice, currently managing patients with GI disorders, including IBS, gastroparesis, and IBD, as well as home, parental, and enteral nutrition patients. She is a consultant and speaker and has lectured extensively nationally and internationally on a variety of nutrition topics. She has authored 4 books and numerous book chapters in peer-reviewed papers and has received many honors and awards. Balancing both evidence-based nutrition with sensible and practical applications is her strong point, which I am sure that we will witness in her presentation today. With that, welcome Dr. Carol Ireton-Jones.
Well, thank you so much, Karen. It is a pleasure to be here to talk with you all, and especially to talk about this topic. The topic of preventing and treating malnutrition outside the hospital is becoming more and more important as people are being discharged from the hospital or do not even go to the hospital and stay at home to recover from COVID-19. As new as the virus is, malnutrition is not new. And treatment and prevention of malnutrition are also not new. Although, however, knowing what groups are affected and what symptoms or organs have been affected allows for more targeted intervention. So in this discussion of nutrition care in adults with COVID-19, I'll describe the potential effects of COVID-19 on nutrition status in adults outside the hospital. We will examine key nutrients that support immunity, and we will identify strategies and guidelines for treating and improving nutrition status in adults outside the hospital. As we all know, these are truly preliminary considerations, but combining sound principles of nutrition care with what we're seeing in people with COVID-19, we can make educated decisions. So I thought it would be nice to get started with a polling question. So you have to interact a little bit here. I would like to know what your practice setting is. So please, I believe the poll is being launched right now. So is your practice setting ICU, acute care, skilled nursing, long-term care, private practice, outpatient? That's me. Or other. You just wanted to know about COVID-19 and nutrition. So I'll give you a little time to take a look at that. Okay, oh my gosh, there are my kin in private practice and outpatient and acute care as well. This is great. All right. Wow, we have almost 72%. So you may be able to see this, but let me tell you the answer that we're seeing now. About 44% of you are in acute care, and the next largest group are 23% in private practice and outpatient care, and then 15% in the ICU. So, and 11% are other, so that's pretty interesting. All right, next polling question. Now that we know the group, how many COVID-19 patients have you seen in practice? These may seem like smaller numbers, but we just thought not everybody is seeing them. So have you seen 0 to 10? Have you seen 11 to 20? Or are you in one of the areas where you've seen more than 20? So I'll give us a little time to answer that question. Okay, it looks like as the vote is continuing, about 58% of you are in the 0 to 10. Now it's about 57% are in 0 to 10, and 30% more than 20. So this is very interesting. Many of us have only seen a small number of COVID-19 patients, and then 30% of you have seen more than 20. So I hope that you find that this presentation is very helpful to you. All right. Thank you for the polling questions. The polling is now closed. All right. Well, let's talk about COVID-19. According to the CDC, COVID-19 is a new and novel virus caused by a coronavirus called SARS-CoV-2. Now, if you haven't looked at that, we've seen it many times, but if you haven't looked at that definition, SARS is severe acute respiratory syndrome coronavirus 2, which results in coronavirus disease 2019, or what we now call COVID-19. Symptoms range from mild to severe, requiring hospitalization. And this continues to be one of the enigmas of the virus and its unpredictability. However, it has been noticed and that there are risk factors that tend to predispose a person to higher risk. As you can see here, these factors are older adults, or really people of any age who have serious underlying medical conditions, such as diabetes, hypertension, obesity, and immunocompromise, especially if those are not well controlled. So it is a novel virus that is wreaking havoc with the world as we know it. Here are factors that contribute to high risk for severe illness from COVID-19. In my reading, most of the reading states that most people have mild to moderate symptoms. However, as you examine these, you'll note that many of the things listed in these factors have nutritional implications that would lead to severe disease. Heart disease, diabetes, liver and kidney disease, cancer. As you see, chronic kidney disease, those are who are immunocompromised. In an analysis of underlying conditions and symptoms among adults hospitalized with COVID-19 across 14 states that was conducted throughout March, researchers reported that approximately 90% of hospitalized patients had one or more underlying conditions. The most common condition was hypertension, and that was about 50% of patients, followed by obesity, 48% of patients, and diabetes, 28% of patients. So you can see that didn't equal 100% because they are comorbid conditions. In a retrospective analysis of almost 4,000 patients with COVID-19 who presented to a large academic hospital in New York City, Jennifer Leiter, MD, and colleagues from the NYU Grossman School of Medicine noticed that 21% had a BMI between 30 and 34, and 16% had a BMI of at least 35. Those younger than 60 years of age with a BMI between 30 and 34 were twice as likely to be admitted to acute care versus those with a BMI of 30 or less. And they were also 1.8 times more likely to be admitted to critical care. So those of you who announced or stated that you were in ICU care are probably shaking your heads knowing that these are the patients that you're seeing. Patients with COVID-19 with a BMI of 35 or greater were 2.2 times more likely to be admitted to acute care and 3.6 times more likely to be admitted to critical care. These findings were published in the April Clinical Infectious Disease, so if you wanted to look at that and for more information. So there are nutrition implications for each of the described conditions that contribute to this high risk. Prevention and treatment remain important with or without a pandemic. So I think we certainly have our work cut out for us. Here is a list of symptoms. These symptoms may appear within even 2 days after exposure to the virus or 3 to 4 days after infection. Um, I think they're commonly we've heard of the cough, the shortness of breath, difficulty breathing, the fever. Other less common symptoms include the GI symptoms, the diarrhea, although that's getting more common, nausea and vomiting, and the newest one, which is the loss of taste and smell, which is highly recognized now. And interestingly, I was reading that now symptoms such as that you would have with a common cold are being seen as part of the symptoms with COVID-19. So it's a multifactorial list of symptoms. In talking with my friends and reading the information from many of the symptom or the sources that I've looked at and colleagues who've worked with COVID-19 patients, it seems that the extreme fatigue and cough are maybe what brings them forward because it's just so different than what would be usual fatigue or respiratory cough type things. So why aren't we able to fight off this COVID-19 if we have an immune system? Now, I think this little infographic looks a lot like what I've seen of the COVID virus. Some of you know this is an orange with cloves on it, but for me, this represents the virus for you. So talking about the immune response, the overall function of the immune system is to prevent or limit infection. The immune system is, and I quote, a complex network of cells, tissues, organs, and the substances they make that help the body fight infections and other diseases. The immune system includes white blood cells and organs and tissues of the lymph system, such as the thymus, spleen, tonsils, lymph nodes, bone marrow, etc. The immune system can distinguish between normal healthy cells and unhealthy cells to prevent or limit infection. The cell damage can be caused by infectious microbes, viruses, and bacteria, or even non-infectious agents like sunburn or cancer. There are two basic types of immunity, as you see here, innate and adaptive. Innate is described as the fast, non-antigen specific immunity, that first line of immunity, and adaptive as the slower, more antigen specific component of immunity. The adaptive system generates immune memory. Innate immunity or the first response occurs when innate immune cells recognize a problem. The innate immune system is made up of physical barriers like skin and gut epithelium to prevent pathogen entry into the body, as well as phagocytic and other cells. Examples of innate immune cells are neutrophils, eosinophils, macrophages, and mast cells. They respond quickly and broadly when a problem arises, creating an inflammatory response that eventually resolves. Innate immune cells are also important for activating adaptive immunity. Innate cells are also critical for host defense, and disorders in innate cell function may cause chronic susceptibility to infection. Adaptive immunity occurs later as the body begins to recognize the invader or antigen and reacts with antigen-specific cells, typically T lymphocytes and B lymphocytes. Adaptive immune cells are more specialized, with each adaptive B or T cell having unique receptors that recognize specific signals. The adaptive system is a system of checks and balances to prevent unnecessary activation that could cause damage to the host. The adaptive system is what creates immune memory. So when an infection with the same pathogen occurs, there is a fast antigen specific response, which is basically how vaccines work. A few more definitions, and this is, I realize, very simply put information on our very, very complex immune system. So, viruses are the small infectious organisms that must invade a living cell to reproduce. And once they do, they they cause cell death, which cause cell death, which releases new virus and infects other cells. Our typical example of this virus is the flu, also measles, chickenpox, and shingles, even the common cold. Treatment for a virus is a challenge because it's primarily symptom relief. So I know many of us, when we have the flu, we're like, give me an antibiotic for that. Well, antibiotics are designed for bacteria and really have no effect on viruses. Although there are a few antiviral drugs which prevent viruses from entering a cell and then, therefore, preventing cell replication. And I am going to talk about one of those. A vaccine prevents infection by the virus by allowing the immune system to fight the infection. This is done through immune memory, if you will, to protect against later pathogen exposure, as I mentioned previously. The antiviral that is most linked to COVID-19 is remdesivir. I think almost everybody in the United States probably knows about remdesivir. It is an inhibitor of the viral RNA dependent RNA polymerase. I can't even say that RNA polymerase with inhibitory activity against the SARS-CoV and the Middle East respiratory syndrome. So, because it was used with the SARS-CoV and the MERS-CoV, it was proposed that it could be effective against our COVID-19. This was studied with over 1,000 patients. It was a double-blind, randomized, placebo-controlled study. These were adults hospitalized with COVID-19 and had lower respiratory tract involvement. The outcome of the study was that the remdesivir was superior to placebo because the median recovery time was 11 days with it rather than 15 days with placebo. So as you can see, the conclusion here, remdesivir was superior to placebo in shortening the time to recovery in adults hospitalized with COVID-19 and evidence of lower respiratory tract infection. It is important to note that you see these are adults hospitalized. This may not be applicable to those with more severe respiratory disease and those who are ventilator dependent. Well, now to go forward to nutrition considerations. What do we know from people who have recovered from COVID-19? I love this. This is kind of stories from the field. I bet you all have read some of these or have some of these yourself. I looked on Monday, and this is an ever-changing number, but on Monday, there were about 2.31 million people worldwide who are recovering from COVID-19, from approximately 5.61 million who had confirmed COVID-19. For us in the US, there were about 506 million people who are recovered from over almost 2 million people who had confirmed COVID-19. So what has it been like to have COVID-19? Since I think we're all very aware of this and looking at things about COVID-19, I'm not a real avid reader of the sports page, but I read this story about Von Miller, who is a Denver Broncos linebacker. So he's a big guy as a linebacker. He already had asthma, which he had conquered to be able to play football. And then he also was a big guy, had a pretty high weight. What he noticed during COVID-19 were the taste and smell changes that occurred. And this affected his appetite. Also, as he recovered, it affected his appetite. So he said, it's just been difficult to eat the amount that I need to eat to maintain my weight. He also noted that he had continued shortness of breath and said, it's just been hard to get my lungs back into shape. Then I noted here the conditioning loss. So he really, in a short period of time with COVID-19, he noticed a big change in his conditioning. So he's going to have to work twice as hard to get back into shape. The second person here, Miss Omer, she is a 31-year-old female. I enjoyed her story because she said, one day I felt perfectly fine, and the next day I had significant fever, diarrhea, fatigue, coughing, body aches, and she said it was the worst headache she had ever had. She was in the hospital for 8 days and was discharged home. But as you can see here, she said it's just been difficult becoming physically active again. Again, the fatigue. She said her coughing took a long time to stop. And then, of course, she had had COVID-19, so they sent her home to be alone. So she was in isolation. And she said it took her about 6 weeks to feel recovered. Now, here is my close encounter with COVID of my friends Martha and Carol. We had spent a couple of days with them the weekend before they said they started feeling really bad from allergies. These allergies were just more than they had been previously. They had similar symptoms, both of them, that would relate to allergies, but they had a cough and they had headaches. And then they started noticing the taste changes, loss of appetite, the fever, and the lethargy. So they isolated themselves for a week. They began to feel better, but they noticed the lingering cough. They were very tired. The fatigue and the poor appetite lasted at least 3 weeks. It took more than that just to recover the energy and about 5 weeks to recover the cough. But they both recovered from COVID-19. What Martha said she thought was very great about this is Martha's in her late 50s, but Carol is 77, and they both recovered well. Why did they do that? Well, the difference was they were both physically fit. They had been eating well prior to the COVID-19, and you know what else? They ate well during recovery, and I think this is key. I noticed I was looking at what to do and looked up on WebMD, and they said to eat healthy food. So there you go. There's the answer to COVID-19. Here are key nutrition related concerns. As you can see here, think about how each of these affect either the ability to nourish yourself or how these affect nutrition status. Obesity, as mentioned previously, is a risk factor and may be associated with other risk factors like sleep apnea, so therefore respiratory challenges, and type 2 diabetes with further complications in recovery. Dr. Steve Heimsfeld, who's a professor in the Department of Metabolism and Body Composition at Pennington Biomedical Research Center, at Louisiana State University is an obesity expert, and he noted that there is some evidence that people with obesity may have impaired immune function and be more susceptible to viral infections because obesity itself promotes a mild chronic inflammatory state. So this may contribute to the susceptibility to COVID-19 and COVID-19 complications. I wanted to put this in because I think this is something that we need to think about. The ICU dietitians and ICU care members who have joined this call have been aware of ICU acquired weakness for some time. We've learned that not only does the disease or injury affect overall recovery, but the time spent in bed and the loss of muscle tone. So the causes are really multifactorial and difficult to avoid. As noted on this slide, repletion with protein or additional calcium has not positively affected bone mineral content loss during bed rest. Additionally, it's difficult to replete or maintain muscle without some type of physical activity. So this may have long-term effects as are currently being discussed with many recovering patients and not even those that are within the ICU. So nutrition considerations. No one really knows the full effects of COVID-19 post-discharge, but we do know how to fight malnutrition. Number one, we need to look at who is at nutrition risk. So that's nutrition screening. We need to evaluate nutrition status, really with or without COVID-19. Determine individual needs and determine whether these are for maintenance or repletion. A very key point during this COVID-19 is, does your client or patient have access to food and nutrition? Then develop and implement a plan and then continue to reassess over time. These are 10 expert statements from ESPN for prevention and treatment of malnutrition in individuals at risk or infected with COVID-19. It was written by Barazzoni and colleagues, and I think you will really enjoy taking a look at this reference. Another excellent resource is by Handu, Handu, and you will see this in the references attached. On malnutrition care during the COVID-19 pandemic, considerations for the registered dietitian nutritionist. Both address nutrition screening and assessment, methods to meet nutrition needs, and monitoring, and are specific to settings as well. The Hindu article provides specific recommendations for RDNs in practice settings. Nutrition screening. It goes without saying, but I think it's worth repeating. Malnutrition is associated with poor health outcomes and longer time to recovery. And this is particularly affecting those we've talked about with comorbid conditions and older adults. So this is an extremely important component of nutrition care. Patients with suspected, confirmed, or even those who are recovering from COVID-19 should be screened for nutrition risk. And if you look at this slide, you'll see that there are some tools that are listed on this slide: the self-MNA, the MST or malnutrition screening tool, and the MNA. These or any other validated screening tool should be used. The MST has recently been evaluated by the Academy's Evidence Analysis Center and recommended for use during COVID. It can be used to screen adults for malnutrition regardless of age, medical history, or setting. And because it's easy to use and validated, addressing decreased intake due to poor appetite and recent unintentional weight loss, this makes it very applicable during COVID-19. I've listed some factors to address in a nutrition screening, and you can see they would be very related to the ones that relate or are applicable to your setting. For example, for me in the outpatient setting, I might be looking more at ability to obtain food, activity level, and depression. So the goal is to identify the risk so that an assessment and intervention can be made. Going further through these guidelines or recommendations that were provided by Barazzoni and colleagues and ESPN, these three statements address number one, Actually, number two, optimization of nutritional status, and who should be looking at evaluating nutritional status. Also, adequacy of diet, which I'll talk more about later. And then it also talks about physical activity. Physical activity we know has been shown to improve mood and well being. And physical activity has also been noted. I've seen people finding interesting ways to increase their activity from walking around their neighborhoods. I certainly know more of my neighbors now doing things in their backyard. Some have been very creative and even in their house doing things that are creative to increase physical activity. After a person has been deemed to be at nutrition risk, a nutrition assessment should be done. For patients in the ICU, biochemical parameters may be more readily available and critical for those individuals rather than those in the outpatient setting. So in the outpatient setting, we may look at things such as more related to amount of weight loss and nutrition focused physical assessment. This is very nicely detailed in the Hindu paper. However, suffice to say, registered dietitians understand and know how to do nutrition screening and assessment as it's in our scope of practice. Within the nutrition assessment, the presence and degree of malnutrition may be evaluated to make decisions on nutrition intervention, and things that may be included are things such as ventilator dependence, location, critical care, ICU care, even lean and fat mass lost. Nutrition focused physical assessment is important, but it may be a challenge if the dietitian is unable to be in the room with the patient. Therefore, we might have to rely more on parameters of how much weight has been lost, how much time did this weight loss occur in, what has appetite been, to extrapolate for potential deficits. We then determine recommended intake, and it could be maintenance or it might need to be repletion. Energy needs can be calculated or measured. Indirect calorimetry can certainly be used. I actually have a indirect calorimeter that I use in the outpatient setting, and I know that it can be safely used in these times with COVID, using careful attention to being very clean with the way things that are measured. It can There are some indirect calorimeters that connect to the ventilators in the ICU, so it'd be interesting to see what kind of data will be coming from this in the future. Predictive equations can certainly be used, and as Karen mentioned in the introduction, you can use the Ireton-Jones equation in the ICU. Just saying, it's fine with me. I noticed in many of the papers I'm seeing calorie per kilogram recommendations of 27 to 30. So that's an idea and something you can certainly use as well. Protein needs, as you can see here, 1.2 to 1.5 gram per kilo, even up to 2 gram per kilo may be used depending on your patient's status. Fat and carbohydrate provide the balance of needs, recommending using non-pro-inflammatory fats, which certainly applies to intravenous nutrition support, and considering higher fat intakes for those patients who are ventilator dependent. Vitamin and mineral needs have received a lot of attention. We know we need to assure adequacy, and particularly the vitamins that have been discussed, and I will discuss further: vitamin C, D, A, E, the B vitamins, and trace elements, zinc, selenium, and iron, and I'll discuss that more in a moment. You need to assure adequacy, that these are adequately provided, but we also need to replete any deficiencies. And finally, hydration and fluids needs to be a part of the nutrition plan, using 30 to 35 milliliter per kilo if somebody has additional losses, accounting for those, and it can be up to 3 liters per day. This is a patient of mine who has said I can use her information anytime to demonstrate the benefit of nutrition and an example of malnutrition. I was able to evaluate her using nutrition focused physical assessment because this is someone that I saw before COVID, but I think that it is instructive that if you can have your patients stand, if you can see them and you're not able to be in the room, or if you are with them and there is a window between you, if they can stand, even evaluating from afar, you can see this person has lost lean and fat mass. You can see her clavicular prominence. And in fact, she had lost 15 pounds in 2 months and weighed 116 pounds at 66 inches tall. Her BMI was 18.7. Now, she also reported she eats very little, and that was confirmed by Diet Recall. So there is no question she is at nutrition risk and requires nutrition intervention. The nutrition focused physical assessment was important and helpful in identifying this, as with a BMI of 18.7, well, that's okay. Not understanding that there had been significant weight loss and poor appetite, these were enough to initiate intervention. So, can nutrients support the immune system? Well, the answer is yes, but note the wording here. Nutrients can support the immune system. They do not boost the immune system, although that terminology has been used throughout the infosphere. I saw that in one of my articles that somebody called that the general social media, etc., infosphere. I love that. So healthy people can get COVID-19, of course, but as mentioned previously, the effect may be much more attenuated if they've had a healthy diet, a healthy body, and they have well-controlled comorbidities. So we have to make sure that anyone who is recovering or has COVID-19, or really any of us today, have adequate vitamins, trace elements, protein, and calories to support the body's maintenance and recovery. Vitamin D seems to have been of great interest in this pandemic. In the study here, there was a noted association between seasonal upper respiratory tract infections, this is also known as the common cold, and low vitamin D levels. This was a cross-sectional US-based study, and higher numbers of upper respiratory tract infections were seen with people who had lower vitamin D levels. And they also even saw a greater association with respiratory diseases with lower vitamin D levels. But there were some challenges in this study in that there were variations of the definition of upper respiratory tract infection. And then also there could be variations in vitamin D level and incidence of cold and flu due to seasonal variations. People spend more time indoors with close proximity to each other in the winter, so that may have been a part of it. But I will say, and I think we could all agree, that all data points indicate higher incidence of respiratory compromise are associated with lower levels or deficiencies of vitamin D. So we do want to correct deficiencies, specifically of vitamin D in this study, but there is no established evidence that routine empirical use of megadoses of micronutrients may prevent or improve clinical outcomes of COVID-19. Vitamins A, what you see here, vitamins A, C, D, E, B6, B12, zinc, and selenium, copper, iron, folate, all are important for the immune system. And as you can see here, that deficiency of these has been associated with viral disease and adverse clinical outcomes. So it's association, but not causation. Thinking about this, then, who might be at risk? Smokers, the poor who have poor access to food, people who have poor intake, people with malabsorptive syndromes, people who have been previously ill, the elderly, etc. So it is important to be aware of this and be aware of the potential for deficiencies. This article by Calder et al. Is just a wonderful article for your references. And he recommends a daily multivitamin and trace element supplement that contains 100% of the RDA, including these vitamins listed here, and trace elements. So that is in addition to a healthy diet. He further recommends that vitamin C in levels of 200 milligrams per day. So that's above the RDA, but within the upper safety limits because the RDA for vitamin C is 60 to 70 milligrams per day, and the tolerable upper limit is 2,000 milligrams per day. And I bet all of us know people who take more than that. For vitamin D, the recommendation is 2,000 IUs per day or 50 micrograms. And the upper limit for vitamin D is 4,000 IU or 100 micrograms per day. So these are recommendations for someone with normal levels of these vitamins and minerals. Always correct deficiencies if they are apparent. And that means assessing micronutrient levels. One other thing that Calder mentioned was adding 250 milligrams of icosapentaenoic acid and docosahexaenoic acid. And this is probably the most complex. From a food standpoint, EPA and DHA sources are great sources are mackerel. 3 ounces has 590 grams of DHA and 430 grams of EPA. So just get your mackerel every day or every other day. Salmon also is a good source, as are sardines, oysters, chia and hemp seeds and walnuts also, but those sources are as alpha-linolenic acid, and so they're actually converted from ALA to DHA and EPA. Patients can take a supplement that is a combination of EPA and DHA, but we need to make sure it's a good quality supplement, no matter which one they take. And quality indicators you might consider are US Pharmacopoeia, NSF International, and also Consumer Lab has some recommendations. Now, finally, in this area, I would suggest you take a look at www.clinicaltrials.gov, and you can put in COVID-19 and nutrition or COVID-19 and individual vitamins to see what studies are going on. It's really very interesting, and I think we're going to know more soon. So nutrition intervention is the next step. We've identified need, we've identified amount, and now we need to think about the intervention to be done. In the ICU, this intervention may be very different than the people that we see here. So think about your client if you're or outpatient. Think about your patient in the hospital, acute care setting, in the SNF, your family member, your friend, your long-term care resident. How do you meet their nutrition requirements? As I think back to my time in the hospital, when we had somebody come in that was malnourished and had lost weight, my favorite thing that we did was we would give them a diet order of times two. So if you haven't seen this, this is a tray that is absolutely brimming with food. How appetizing is that? Clearly, that wasn't the answer. With COVID-19, there are even more considerations than appetite. Maybe your patient is hungry, but they get tired really fast, so they don't have time to make food, or they have difficulty breathing, so they can't really eat at one time, or they have the taste changes, etc. This is a really difficult scenario. So, how do you meet oral nutrition needs? Food. Since COVID-19 started, I have never seen so many home cooked meals pictured on Facebook or Instagram in my life. People are making sourdough bread starters and they're baking. You couldn't get yeast or flour for a long time, which is great, but this takes time and energy. And that's not really what people with or recovering from COVID-19 have. So, therefore, food prep has to be easy. Frozen meals that can be microwaved or easily heated, using canned fruits and vegetables, having home prepared meals provided for you or home delivered meals can be very helpful. Also, home delivery of groceries. I bet many of us have taken advantage of that. Also, the food should be nutrient dense, and this is important when reading labels and looking for protein and nutrient content. I decided to Google nutrient dense foods so I could give you some nutrient dense foods as recommendations. And the first nutrient dense food I saw in this, my first Google, was number one was salmon, and number two was kale. Kale is nutrient dense. And if that's your fave, that's great, but it's not terribly calorie dense. So perhaps we need to think about nutrient dense and calorie dense additions to foods like cheese, nut butters, avocado, nuts, dried fruits, milk, cottage cheese. My all-time favorite, non-fat dry milk, and making sure people feel comfortable using easy to prepare foods like canned foods and frozen meals and veggies. This is where oral nutrition supplements, or ONS, becomes very important. Commercially produced ONS, or oral nutrition supplements, can be obtained at the grocery store, in pharmacies, and can be home delivered. I believe almost all of them are available on Amazon.com. They can also be based on an individual's needs, whether it relates to fluid needs, calories, protein. They can be higher in protein. Barazoni and colleagues, in the article that we've been looking at, states that ONS can be used to improve nutrition intake by providing at least 400 calories per day as ONS, including 30 grams or more of protein per day, and should be continued for at least 1 month. And this is true for our nutritionally at risk or malnourished individuals, or those who just need a source of nutrition. And this can be even longer than a month. Continuing on with some of the statements, in statement number 5, this further details the guidelines that I just mentioned. So, in COVID-19 patients that are non intubated, it is recommended to meet the energy target with oral nutrition. And here you see this statement again, using oral nutrition supplements, or ONS, again, providing 400 calories per day with 30 grams or more of protein per day, continuing for a month, and then reassessing and maybe continuing. And as you see here in statement number 7, we'll get to statement number 6, but it also here in this, if there are limitations in the enteral route, it is advised to use intravenous nutrition supports. When thinking about an oral nutrition supplement, here are some recommendations to consider, and these are what I consider in my practice. In my opinion, they should contain 20 to 25% of the DRI, RDA for vitamins and minerals, and 15 to 20 grams of protein. This should usually be within, in my opinion, within 8 to 12 ounces. If more than 12 ounces are needed, this could make drinking the ONS more difficult. Commercially made ONSs likely meet this recommendation. Of course, you can use homemade or fast food shakes. They can be obtained from restaurants. I'm sure you can think of a few of those now. However, these may have calories, but not enough protein. So I looked up my favorite. In 12 ounces of a chocolate frozen dairy dessert, there are 54 grams of carbohydrate. This is my favorite one. 8 grams of protein, 6 grams of fat. I was happy to see 350 milligrams of calcium, but not much else. So they may not meet the nutrition needs of that we'd like to meet. Also, number one in nutrition content of oral nutrition supplements, does it taste good? Some people may need sweet, some people may need unflavored. Our older individuals probably like sweet because that sweet taste is a sense that is maintained for some time. So, as mentioned previously in the ESPN guidelines, individualized for the nutrition plan for the individual, use ONS for at least a month. So that means that providing just a six pack of product won't do it. You really need to continue it. I'd like to give you now my experience. This is my personal experience with a 92-year-old female who had a pneumonia and was admitted to the hospital for 5 days for IV antibiotics. She was just DC'd from the hospital, but rehospitalized for another 5 days, just wasn't doing as well, and then discharged to rehab. So, as you can imagine, she didn't eat very well during the time in the hospital, so in rehab, she was able to start to eat again, but this is where the oral nutrition supplement, in particular chocolate for this individual, became so important. Initially, it was a high protein, high calorie product, and she would have one or two a day, depending on her meal intake. At home, this continued with the high protein, high calorie oral nutrition supplement, 1 to 2 daily based on meals provided at home. Ongoing, she liked it so much that she always had at least one per day, and she'd have another one if a meal was missed. So the outcome of this is she continued her oral nutrition supplements until she was 96 years old. She did go from high protein, high calorie to high protein, regular calories. Now, just to summarize, for those of you who are dealing in enteral nutrition and ICU patients, the rest of these guidelines or recommendations are very helpful, and certainly you'll look through these and maybe employing these now. So the bottom line in nutrition and nutrition support, we have many options. We have oral, enteral, parenteral. They can be combined, but oral nutrition supplements can be a part of each of these. So the goal is to just get started. In summary, nutrition as status is affected during recovery from COVID as it is during COVID. There is an increased risk for malnutrition in COVID-19. We should pay careful attention to assuring adequate protein, calories, and micronutrients, including vitamins and minerals. Using oral nutrition supplements, we can provide targeted protein, calories, and micronutrients. Something a little new and of interest, supplementation of individual micronutrients is recommended in cases of deficiency, and a daily multivitamin trace element supplement meeting 100% of the RDA has been proposed to support immune health. In fact, there are recommendations to go along with that are higher levels of vitamin D and C as well. But overall, continuing to eat well and managing comorbidities is a healthy recipe for the future. So, not just now, but always. And a quote that I like very much: in recovery, there is hope. So, I would like to thank you very much for your attention to this presentation and for Karen inviting me to do this timely and important presentation. You will see there are references and resources for you here. So Karen, I'll turn it over to you, and I hope we have a few minutes for questions.
Yes, thank you so much, Dr. Ireton Jones, for just an outstanding and timely presentation. Okay, so here we go. We have a question. Um, Dr. Ireton Jones, what is your experience thus far with COVID-19, and how do you think the dietitian's role may evolve during the pandemic?
Well, that is a great question. And my experience with the pandemic has been that I am as you know, I work in outpatient with GI and home parenteral and enteral patients, and I have found more patients contacting me because they are very interested in improving their nutritional status. So I think, and they don't have COVID-19. So personally, I haven't had to take care of a COVID-19 patient. However, I have had friends who have COVID-19 and are recovering and have sought my advice. And I must say, I feel much more capable of doing that after reviewing the literature with you for this presentation.
Okay, awesome. We have another question here. Can you comment on long-term effects of COVID-19 on patients?
This is what we're seeing now being discussed in the literature, and we already knew, as you saw from the suggestion or from the cases that I mentioned, people say it takes 6 months, 6 weeks, 3 weeks, they just don't feel better. And if you have lost body mass and you have not carefully improve that with better nutrition, I think that recovery is going to be very long, in fact, very prolonged. So, um, and we just don't know. Is it going to compromise respiratory function? Is it going to make complications more pronounced? So I think since so many of these are nutrition related. Going back to the other question, I think dietitians are going to be in great demand because nutrition is so important in every one of these.
Okay, next question. What is the best way for outpatient dietitians to help patients obtain ONS? And does insurance or health plans cover ONS?
Well, being there, I think that is a very important question. So the first thing that comes to my mind and what my patients have utilized is if they have a health savings account, oftentimes that can be used to purchase commercial ONS. And so I would suggest that. You can certainly talk to your provider and see if, given this very interesting time of COVID, if it would be something that might be exceptionally covered. And then I believe that ONS are covered through the SNAP program. So those are the first things that I would recommend. And certainly, dietitians are in contact with the manufacturers. And so we can help our patients, I think, greatly that way.
Okay, great. In California, can our outpatient clinics with outpatient dietitians screen and treat malnutrition, or do they need to be referred to their primary care physician?
That is a great question. And although I'm not in California, I can certainly relate to the question because the patient that you saw in the slide, it is a patient of mine who I clearly diagnosed with malnutrition. So what I did was I used my screening tool and the additional information to share with her primary care provider so that we could take that next step in intervention. And I think the primary care provider was very happy to receive that. And I think it was not just an option, but an obligation for me as a dietitian to let her physician know. So this would be a part of her overall treatment plan.
Okay, and I have actually one last question here, okay?
Okay.
What are the common nutrient deficiencies that have been identified in COVID-19 patients?
Whoa. Well, we are going to find out more and more, but I think that this, I'm not sure that I know which are definitely related to COVID, but I think we can look back into this presentation and certainly think vitamin D has been associated, lower levels have been, and deficiency have been associated with respiratory infections. But I think overall, any deficiencies, as you noted when I listed all the vitamins there, I was thinking, which one did I not include? So I think there could be potential deficiencies of vitamins and our minerals as well, trace elements. So I think supplementation is at least assessment for deficiencies, and supplementation is going to come out as a big part of our care with these patients.
And we are certainly going to learn a lot more in the days to come and the years to come, right?
Yes, I think so.
Yes. Okay. All right. Well, thank you so much, Dr. Carol Ireton Jones, and thank you to all healthcare providers striving to give the best possible patient and nutritional care, especially during these challenging days. And on behalf of the Nestle Nutrition Institute, we truly hope that you found this information useful to your practice. Enjoy the rest of your day, and please be healthy and safe. Thank you.
Thanks, Karen.